guess I should thank Cal for making all my 4 presentations be today, so I keep coming up here on the stage and you're probably getting sick and tired, especially of these initial slides. But I wanted to talk about lupus nephritis in children and then expand a little bit on other vasculitides in children that are also of interest and involve the kidneys in significant ways. And as I mentioned in my first presentation this morning, I found a very current reference from the Middle East talking about kidney biopsies in children that have somehow been tracked in a variety of countries in this region of the world. And like I said this morning, in terms of primary glomerular diseases, it were the main culprits in nephrotic syndrome, minimal change disease, and FSGS that were found in the majority of kidney biopsies that could be tracked. This is just a study design, which I explained already this morning. But if you look at the secondary glomerular diseases in children who had trackable biopsies in this region of the world, by far the most common findings on those biopsies were some type of lupus nephritis. So once again, we're talking about something that's relevant. And to make it even more relevant, I also pulled a couple of review articles about lupus and especially lupus nephritis in children. Oops, that was too much. Scott is a pediatric nephrologist at Baylor in Houston who has an interest in this and who is one of the leaders of everything we learn about pediatric lupus in one of our research networks in the United States called the Midwest Pediatric Nephrology Consortium. Hermine Brunner is German like myself, and she's a pediatric rheumatologist at Cincinnati Children's where I overlapped with her. So I can vouch for both of these people and what they write in their review articles. As you know, lupus or the diagnosis of lupus with or without nephritis hinges on diagnostic criteria. One diagnostic set of criteria is the one that's been proposed by the American College of Rheumatology with 11 potential indicators of lupus, and in order to meet the diagnosis of lupus, you need to meet, or your patient needs to meet at least 4 of those 11. And of course, one of them is evidence of renal disease. Evidence of renal disease, obviously, if it's bad enough, will appear on your blood work with an elevated creatinine and perhaps some hypertension and stuff. But in lupus, in patients with lupus, when we try to assess whether or not they have renal disease, we're still pretty simplistic, and we like to look at the urinalysis. Anybody who has extrarenal lupus and an abnormal urinalysis, meaning hematuria and or proteinuria on urinalysis, has a high enough likelihood of having renal involvement as well to warrant and justify a kidney biopsy. So my simple rule, if I help take care of patients with lupus, is if they have a normal urinalysis, the likelihood that we would find something in the spectrum of lupus nephritis of biopsy on biopsy is so low that that person probably doesn't need a biopsy at that point. If there is hematuria and proteinuria, on the other hand, it's very hard for me to have anybody convince me not to recommend a kidney biopsy. The other thing you have to keep in mind is that some of these lupus criteria, and especially the renal involvement, don't necessarily all happen at the same time. So I have a patient who has rip-roaring lupus nephritis on kidney biopsy and has no other diagnostic criteria for lupus. I just got him biopsied because he had a lot of red cell casts in his urine and intermittent gross hematuria. And sure enough, he had some of the classic findings of lupus nephritis on kidney biopsy that we're going to get into. And then there are patients who start out with meeting 5 or 6 non-renal criteria for lupus and have a very bland urinalysis and no non-biopsy evidence of kidney disease at the time, only to a month or 2 or 3 or 4 later develop more evidence of renal disease and then require a biopsy to classify their renal involvement. Some of the things I'll show you is from another review that's also very current, just came out in Pediatric Clinics of North America, including these beautiful pictures of lupus nephritis types. As you know, while we can have a high index of suspicion that we're going to find some kind of lupus nephritis in somebody who has lupus and has abnormal urinary findings, we're not very good at predicting what type of lupus nephritis histologically we're going to find on a biopsy. And when I say type, we usually use the WHO lupus classification 1 through 5. And it's important to get that information with a biopsy because that affects therapy. The milder forms of lupus nephritis, class 1 and 2, are shown here. Class 1 lupus nephritis is basically almost like minimal change disease, very normal glomerular and very vascular and glomerular findings, maybe a little bit of mesangial cell proliferation that then in class 2 nephritis becomes a little bit more pronounced. The mesangial proliferation does, but no deposits or anything like that that we'll see in the more severe types of lupus nephritis. Class 5 lupus nephritis is basically membranous nephropathy in the context of lupus and comes with a fair amount of deposits that are characteristically located outside of the glomeruli there along the basement membrane. And this is what this looks like on electron microscopy. This is the lumen of the glomerular capillary. You can still see some erythrocytes in there. And all these black dots here are deposits in the glomerular wall, glomerular capillary wall, consistent with membranous lupus nephritis, which is basically class 5 lupus nephritis. What about the more severe types of lupus nephritis, class 3 and 4? You can tell that these glomeruli, whether they're histological pictures or whether they're a schematic drawing, look very ill and very abnormal, with things like fibrinoid necrosis or even crescent formation, and of course deposits that not only are in the mesangial area but also within basically the capillary membrane, not necessarily on the outside in that typical pattern of class 5 membranous, but they're in various locations within that capillary wall, subendothelial or some other locations. And then the difference between class 3 and class 4 is only on your biopsy how many glomeruli are affected by these severe changes, severely proliferative changes. If it's less than half of the glomeruli sampled on the biopsy, it's class 3 WHO lupus nephritis. If the percentage of affected glomeruli on the biopsy sample is above 50%, it's diffuse or class 4 WHO lupus nephritis. I don't have time to go into the details of how lupus, especially based on what type of WHO class you find histologically, if there's renal involvement, how that is treated. The rule of thumb is obviously, at least initially, there's always a fair amount of steroids in the mix. And then if there is significant, i.e. proliferative class 3 or class 4 lupus nephritis on biopsy, then that steroid therapy needs to be augmented with some type of anti-proliferative therapy, which historically was cyclophosphamide. Almost historically, a little more recently, it's been shown that cyclophosphamide is essentially equivalent to mycophenolate mofetil or MMF or Cellcept, which is a little better tolerated, but just like we talked about when we spoke about nephrotic syndrome, Cytoxan historically and still oftentimes in lupus is given with IV infusions, so you know it's going in. MMF has to be taken twice a day by mouth, and we have, unfortunately, amongst our lupus patients, especially because they happen to be oftentimes teenagers, we sometimes have doubts how successfully we can ask them to take medicine several times a day on a long-term basis. And then mostly for extrarenal manifestations, there are additional therapies like Plaquenil, for example, and then depending on whether they have things like anti-phospholipid antibodies or lupus anticoagulant, some anticoagulation that is also added to the mix. Interestingly, at least to me when I prepared this talk, there is also now a secondary set of agreed upon consensus quality indicators for the treatment of childhood onset lupus. And so these are not drug treatments so in the primary sense for lupus, but other recommended treatment modalities or interventions for children with lupus, ranging from using sunscreen, from regular eye exams if antimalarials are used as part of the lupus treatment, the whole cardiovascular focus about exercising, weight control, et cetera, some renal things that have to do with blood pressure and proteinuria, which we'll talk a little bit more about, and then making sure there's all the vaccinations available and being given that are indicated for these people on long-term immunosuppression, and then some more cognitive / quality of life tracking as well. This slide, you don't have to pay attention to every number on here, but this was part of one of these review articles that showed outcome in pediatric lupus nephritis over time. So the first references included here are from the 1950s and 60s. And as you can see, neither patients did very well survival-wise, nor did their kidneys survive very well in those early days. And then there are two more things I want you to see once again without paying too much attention to all the individual numbers. Relatively more recently, those numbers improved to the 80–90% range, both in terms of patient and in terms of kidney survival in the 1990s. Since the 1990s, as we're approaching 2020 now, so almost for the last 25 years or so, those numbers have no longer improved further. They're still hovering somewhere in the 90s, and so there may still be an opportunity for improvement. So the conclusions for this part, the lupus part of this talk, are that lupus is the most common secondary glomerular disease in also Arab children who are undergoing a kidney biopsy. And then the conclusions from some of these reviews. Obviously, lupus nephritis is a type of glomerulonephritis. If there is significant kidney involvement, oftentimes there needs to be the administration of additional immunosuppression that might not be needed if there was no kidney involvement, just extrarenal involvement. We talked about the importance of biopsy and then some of these follow-up measures that I mentioned. And in that last complicated slide, while we've seen progress between 1950 and 1990 in terms of outcomes for children with lupus, that has slowed down more recently. So briefly, some aspects, renal aspects for other pediatric vasculitides, which are basically Hsp nephritis, and then what used to be called Wegener's granulomatosis, now we call it, I guess it's not tongue-twisty enough to call it Wegener's, so it's granulomatosis with polyangiitis, or GPA. That's the type of vasculitis that is usually associated with ANCA antibodies. And then anti-GBM nephritis, and there's sort of then some rare others. We've had in the last 2 or 3 years two kids who had an overlap of these two. They were both ANCA and anti-GBM positive. They had very bad kidney involvement. We treated them. One we're still treating, and we don't know how aggressive to be because her biopsy looked so horrible and she's not making any urine. The other one we treated very aggressively. We got her into trouble, and she never came off dialysis despite all of our attempts of intervention. I'm happy to say, though, that she got transplanted half a year or last year sometime, and she's been doing very well. So Hsp nephritis, here's, if you like colored pictures, here's all you need to know about Hsp nephritis. It has to do with IgA molecules that misbehave as they're generated in usually the intestinal mucosa and then lead to immune complex deposition in the glomeruli and to nephritis that way. For those who are overwhelmed by this complicated and colorful schema, like me, I summarized sort of our nephrological party line about Hsp nephritis in this table. So kids with HSP have about a 50% chance of developing renal involvement. Just like with lupus nephritis, that renal involvement doesn't always happen at the same time as the HSP manifests with the joint symptoms, the GI involvement, the typical rash, but there can be a lag in the occurrence of Hsp nephritis, and that's where the recommendations are coming from to screen these kids with a urinalysis roughly every 2 weeks for 6 months. If somebody who has HSP without evidence of kidney involvement maintains a normal urinalysis for 6 months, the likelihood that they're going to at some point develop Hsp nephritis is very low, but there can be up to a 6-month lag between the initial presentation of extrarenal HSP and the occurrence of Hsp nephritis. Thankfully, Hsp nephritis is usually self-limited and has a very good prognosis. That being said, there are very severe cases of Hsp nephritis that require not only a biopsy and some aggressive treatment trial, but that can lead to loss of kidney function, chronic loss of kidney function, and need for a transplant. Fortunately, those are the exceptions. Usually, Hsp nephritis may wax and wane a little bit like the disease, but eventually be self-limited and recover. That's especially helpful because there's really no established treatment for Hsp nephritis. We sometimes feel like we should try steroids or some other immunosuppression. None of that has been shown to work. And when we get phone calls by our referring pediatricians, hey, I have a kid that developed HSP 6 weeks ago. Now he or she has an abnormal urinalysis. What should we do? We usually say probably nothing, because nothing has been shown to work for the kidney part, except if that evidence of kidney involvement is bad enough, then you should probably send this child to us for a kidney biopsy, and bad enough is defined by an elevated creatinine or by having full-blown nephrotic syndrome as the manifestation for this Hsp nephritis. And if we do a kidney biopsy, the board question, of course, is that in HSP, just like in IgA nephropathy, the characteristic diagnostic finding is the predominance of IgA deposits on immunofluorescence. We expect that. We can tell this kid has HSP from the extrarenal signs, so we know that's what we're going to find, and not what we're looking for. What we're looking for is how many crescents are there, how many glomeruli are how badly affected, and we have criteria to then pull the trigger if it's bad enough and try aggressive immunosuppression to hopefully salvage these kidneys. GPA and anti-GBM nephritis, I've sort of juxtaposed here because they, like I said, they can even occur together, and they certainly have some features that are similar. I mentioned that in GPA, you usually find P-ANCA or C-ANCA, whereas in anti-GBM nephritis, you find anti-GBM antibody in the blood. GPA has a characteristic, let's see. GPA has a characteristic combination, as originally described, of renal involvement and usually granulomatous upper respiratory tract involvement. So those are kids who may have had a history of a lot of quote-unquote sinusitis or nosebleeds, and then some ENT looked around in there and found granulomatous lesions. But you can have GPA only involving the kidneys without much upper respiratory tract involvement. Anti-GBM nephritis, obviously, is called good pasture syndrome if it has the characteristic combination of pulmonary hemorrhage and renal involvement. Remember, that only happens in about 50% of the time. There are 50% of patients with anti-GBM nephritis who have no pulmonary manifestations, no pulmonary involvement. So you need that kidney biopsy to characterize and confirm things. What do you find on kidney biopsy? Well, once again, in GPA, you find what's called pauci-immune immunofluorescence, so no significant immunofluorescent findings. And again, we do that biopsy in part to see that pauci-immune pattern and make us suspect GPA more, but more importantly to see how severely the glomeruli are inflamed or even already chronically damaged potentially. And in anti-GBM nephritis, we find that linear IgG that's directed against the glomerular basement membrane on immunofluorescence. And in addition to that, we get an idea of how badly that kidney is inflamed, how badly it's being damaged. Is there some chronicity already, which all help us come up with treatment regimens. For GPA, the mainstay of treatment, again, is kind of like lupus. You start out with high-dose steroids, and then there are good studies now, both for the induction and the maintenance phase of treatment in GPA, that Rituxan and Cytoxan are equivalent. And in some really bad cases, many, including we, would even consider combining Rituxan and Cytoxan to really pull out all stops. In anti-GBM nephritis, the treatment regimen looks somewhat similar, but there's a more pronounced role of plasmapheresis as well, presumably to get that anti-GBM antibody out of the system of these patients. And I think here comes, yep, there's my shukran again. Thank you very much.